discuss the unique pathology that occurs with inflammation, the inflammatory reaction. Inflammation is the reaction of blood vessels and immune cells to injury, leading to the accumulation of fluid and white blood cells or leukocytes in extravascular tissues. And this involves multiple steps. It involves the release of fluid from vessels, the attraction of leukocytes by chemotactic factors, the activation of chemical mediators, including cytokines, the removal of debris and repair of injured tissues. It involves the main parts of the immune system, which includes antibodies and leukocytes. Now, there's two different types of inflammation that we describe in pathology. There's what we call acute inflammation, which mostly involves neutrophils, and chronic inflammation, which mostly involves lymphocytes and macrophages. Now, acute inflammation is an early response to injury. So acute infections, chemical agents, etc. Now, one thing that you need to be careful of is when we say acute and chronic inflammation, we're not necessarily referring to the chronicity or the timing of the inflammation, though that sometimes does correlate. What we're referring to is really the components of the inflammation. That's why we call it acute. So in acute inflammation, what we see is vasodilation and increased blood flow. This causes redness and swelling. You get disruption of endothelial cells, which allows the contents of the blood vessels to exit the intravascular compartment and leak into the extravascular compartment. And then you get margination of leukocytes, particularly neutrophils, that then move to the site of injury and start to do their job. Now, this neutrophil migration is followed in time by a monocytic and a lymphocytic infiltration as well. So here's a schematic of what this looks like. In normal tissue, you have normal blood flow. You have a few immune cells in the extracellular matrix, occasional lymphocytes and macrophages. But with an inflamed tissue, you get dilation of the arteriole, you get increased blood flow, and you get the blood vessels, the capillaries become leaky. You get edema from leakage of intracellular fluid, and you get deposition of plasma proteins and inflammatory cells in the tissue. Now, edema is caused by this increased interstitial fluid. So when we get the swelling associated with increased interstitial fluid, we call that edema. And edema can come in one of three forms. You can have a transudate, which is a low protein content, low specific gravity type of anemia, where the fluid is basically squeezed out without much protein and without much cellular material leaving. And so transudate is low protein, low cells. Basically a filtrated blood plasma. And that comes because there's some hydrostatic imbalance, which we'll describe more when we talk about hydrostatic problems in a different lecture. Now, an exudate, on the other hand, is a very cellular increase in fluid. So you get opening of the endothelium, you get migration of cells out into the interstitial areas, the extracellular areas, and fluid follows that. So you get also lost protein, and as that breaks down, you get a lot of cellular debris and a high specific gravity. Now, if that exudate is accompanied with lots of neutrophils and debris, we call that a specific kind of exudate called pus. So here's an example of how you would get a transudate. You have hydrostatic pressure causing fluid to leave. You have osmotic or oncotic pressure causing it to come. So any disruption in that is going to lead to loss of fluid, and you'll get edema. We'll talk more in detail about that in the hydrostatic section. So how do the leukocytes get through the endothelial cells into the extracellular compartment? Well, the first thing you get is vasodilation, and so you get an influx of more blood into that area. Now, what happens next is you get expression of particular adhesion molecules on the surface of the endothelium. And these are things like E-selectin and P-selectin. And these bind to oligosaccharides like the sialyl-Lewis X protein or saccharides on leukocytes. The leukocytes then are able to roll and attach to the endothelium, and then they express chemokines, things like TNF-alpha or IL-1, which cause increased expression of adhesion molecules on the endothelium, and the cells then can roll and then hold fast to the endothelium. What happens next then is you get transmigration of these cellular components through the endothelium into the extracellular space, and that involves additional endothelial adhesion molecules, things like ICAM1 and VCAM1 on the endothelium, with integrins on the leukocytes. The process of transmigration of the leukocytes across the endothelium is called diapedesis, and that involves an interaction with a protein called a cell surface protein called CD31. Once it's in the extracellular fluid, then it's got to find its way to the site of injury, and that occurs by chemotaxis. There are things like bacterial products or endogenous products like complement factors, leukotrienes, and cytokines, which attract the leukocytes to move to the area of damage, inflammation, or infection. So here's an example of how that whole process occurs. You start by increased expression of P-selectin and E-selectin caused by cytokines. The leukocyte then attaches and starts to roll. Then the expression of chemokines increases the adhesion molecule expression, and you get an integrin or a high efficiency, high affinity integrin interaction, which causes the cell then to hold fast to the endothelium. Then there's an interaction with PCAM1 or CD31, which leads to the diapedesis of the cell through the endothelium. And then you get chemotaxis. You get movement of that neutrophil or whatever the leukocyte is to the site of injury via chemotactic factors. Now, the types of inflammatory cells that you see in acute inflammation are things like neutrophils, which occurs in like the first 24 hours. You get a neutrophilia. This is especially associated with bacterial infections and infarctions. In the next 2 to 3 days, you see a migration of monocytes, macrophages, and lymphocytes into the area. Now, eosinophils are a specialized type of immune cell that you see particularly infiltrating areas of allergic or parasitic infections or certain tumors. So here's an example of early inflammation. Here's the neutrophilic infiltration you see in the early hours following a myocardial infarction. Over time, though, over the next few days, you get a mononuclear infiltration of lymphocytes, macrophages, and monocytes, which invade the area. What happens then, there's a purpose for this order. The neutrophils come in, they release digestive enzymes and things like that and break down the tissue. The monocytes and macrophages then come in to phagocytose all of this cellular debris. And that occurs via recognition and attachment. You have immunoglobulins or complement factors that are bound to the surface of these dying cells. These are called opsonins. The phagocytes, the monocytes and macrophages, recognize those opsonins. They attach, they engulf, and they merge the resulting vesicles with lysosomes to lead to the killing and degradation of that tissue then. So here's an example of the way that this would occur. In this case, we show it in terms of a microbe, but it's something that binds to the surface of the phagocyte. It gets engulfed. It forms an intracellular vesicle. This vesicle fuses with lysosomes. The lysosomes have enzymes then which degrade the contents of that vesicle. Now, killing and degradation is the function of neutrophils. And killing refers to microbes, and degradation can refer to both microbes and normal tissues. There are two types of killing. There's oxygen-dependent and oxygen-independent killing and degradation. The oxygen-dependent is the most efficient system, especially for killing bacteria. And in this case, there's an NADPH oxidase that produces free radicals. It produces peroxides. And then myeloperoxidase, which again is a lysosomal protein, is an enzyme which converts that hydrogen peroxide with the halide or chloride molecule and converts the hydrogen peroxide to hypochlorite, which is a potent free radical reactive species which can kill the bacteria. That's the oxygen-dependent method. The oxygen-independent method uses regular enzymes, things like lysozyme and proteases and nucleases to break down debris in cells. Now, there's some diseases that occur when this neutrophilic phagocytosis and killing mechanism no longer works. One of these is called chronic granulomatous disease. And this is an X-linked disorder that's caused by the absence of NADPH oxidase. So in this case, the cells can engulf organisms, but they can't kill them because they can't produce the hydrogen peroxide required to kill them. And so anything like Staph aureus, which produces catalase and can break down hydrogen peroxide, will be immune to killing by phagocytes. And so this leads to granulomas and chronic infections in these individuals. Another example is a disease called Chiari-Kagashi syndrome, which is an autosomal recessive defect in microtubule formation. And so in this case, you make the enzymes just fine, but you have difficulty making the phagocytic vesicles or fusing the phagocytic vesicles with the enzyme-containing lysosomes. And so in this case, it also affects melanocytes, and so these people get albinism as well, and it can affect the cells of the nervous system as well, causing a peripheral neuropathy. But what you get is a neutropenia, you get defective granulation, you get delayed killing of organisms, and so they get chronic infections as well. What you see morphologically are large cytoplasmic granules in the granulocytes, the lymphocytes, and the monocytes, which are granules which never do their job. They just accumulate material because they're defective in killing. Okay, so those are the basic cells of inflammation and the process by which inflammation occurs. Let's talk about some of the chemical mediators of inflammation now. Now, the chemical mediators of inflammation originate from the plasma or from immune cells or other cells, and their production is usually mediated by some inflammatory response. These are short-lived mediators which act in the same general area as the inflammation and lead to specific inflammatory responses. Here's an example of some of those. These are things like histamine, serotonin, the prostaglandins, leukotrienes, and so forth, the kinin system, as well as the coagulation system, and then the complement system as well, which all mediate an acute inflammatory response. Well, I want to review a couple of these with a little bit more specificity. One of these mediators is a substance called histamine. Histamine is responsible for increasing capillary permeability, and it's released from basophils and mast cells and platelets when the basophils or mast cells interact with IgE or with anaphylatoxins, that's complement factors C3A and C5A. When those things bind the cell surface receptors, basophils and mast cells release histamine. Platelets, when they aggregate and when there's endothelial injury, they release histamine as well. What this does is it increases the capillary permeability, and this is part of what causes the swelling, the edema, the loss of cells into the extracellular space, and that's the purpose of histamine. That's what it mediates. Serotonin acts like histamine, though, but it's more potent, and it mostly comes from platelets and is released with platelet aggregation. Complement is a set of plasma proteins that assist in the lysis of cells, and they also modulate inflammation, phagocytosis, and lysis of microbes. The main purpose of complement is to be an antimicrobial system. There's basically three pathways that lead from the identification of a microbe to the activation and cleavage of a protein called C3. C3 then cleaves another protein called C5, and then that activated C5 leads to the formation of a membrane attack complex, which puts a pore in the membrane of the offending bacteria and leads to its cell death. In addition to that, some of these cleavage products, C3A and C5A, are referred to as anaphylatoxins because they're chemotactic factors which lead to the influx of inflammatory cells and other inflammatory mediators into the site of injury. So here's a schematic of how that happens. Here are the three different pathways, and you don't need to know these in detail. Just know that these are microbe recognition pathways that lead to that converge on one final point, which is the activation of C3b and deposition of that on the microbe. And again, that leads to the recruitment of inflammatory mediators, it leads to phagocytosis, and it leads to the formation of this membrane attack complex, all of which lead to the attack and degradation of whatever offending microbe is present. Now you can imagine that complement, if it got out of control, could also kill host tissues, and you don't want that to happen. So host tissues have inhibitors of complement on their surface. One of these is called the C1 inhibitor, or C1-INH. C1 inhibits both the complement cascade via the protein C1 and also the kinin kallikrein system, which we'll talk about in a little bit. And when there's a defect in which you have absence of the C1 inhibitor, and this leads to a disease called hereditary angioedema, in which you have overactivation of the kinin kallikrein system, leading to massive edema from increased permeability of the vasculature. In addition, there's two proteins one called decay accelerating factor and another called membrane inhibitor of reactive lysis. And these are on the surface of cells. The decay accelerating factor destroys the C3 convertase. It blocks the cleavage of and activation of C3. The membrane inhibitor of reactive lysis inhibits the formation of the membrane attack complex. And those sit on normal cells of the body and prevent complement from being activated and destroying our own cells. In hematopathology, we'll learn about a disease called paroxysmal nocturnal hemoglobinuria, which results from the absence of decay accelerating factor in the membrane inhibitor of reactive lysis, leading to a hemolytic anemia. Now, there are also diseases in which the formation of the membrane attack complex is defective, and these cause, in particular, an increased risk of Neisseria infections. Now, another chemical mediator is arachidonic acid and all of its metabolites. Arachidonic acid is a polyunsaturated fatty acid that's derived either from the diet or from conversion of linoleic or linolenic acid. It's usually found in phospholipids, and it's activated by particular signals which cause it to be released from membrane phospholipids by phospholipase A2. Once it's released from phospholipids, then arachidonic acid can be metabolized into one of two things. It can be acted on by an enzyme called cyclooxygenase to yield thromboxanes and prostaglandins. Thromboxane A2 causes vasoconstriction and platelet aggregation. Prostaglandins lead to vasodilation and inhibition of platelet aggregation, things like prostacyclin. They also lead to inflammation and modulate the inflammatory response. Now, cyclooxygenase is inhibited by the nonsteroidal anti-inflammatory drugs and aspirin and the specific HOX inhibitors, and through that method, these have an anti-inflammatory effect. The other metabolite of arachidonic acid is leukotrienes. These are synthesized when arachidonic acid is acted on by the enzyme lipoxygenase. And leukotrienes are also inflammatory mediators. The A4 and B4 leukotrienes cause vasodilation and inflammation. The C4, D4, and E4 cause broncho and vasoconstriction. And so they're important mediators of asthma, for example. And there are anti-leukotriene drugs which we use to treat asthma. So here's just a schematic version of this whole process: the formation of prostaglandins from cyclooxygenase and the formation of leukotrienes from lipoxygenase. Now, other inflammatory mediators include the cytokines. These are soluble proteins which are secreted from inflammatory cells, especially lymphocytes, monocytes, and macrophages. There's lots of cytokines, and they modulate the immune response in a lot of different ways, but the key ones to learn are IL-1 and TNF-alpha. These are secreted by monocytes and macrophages, and they mediate what we call the acute phase response, which includes fever and malaise, causing increased sleep, causes neutrophilia, and decreased appetite. This is a response to inflammation, which allows your body to focus on dealing with the important issue at hand. Now, the kinin system I referred to in passing just a minute ago, this is a system which is activated by actually a clotting factor called factor 12A, or Hageman factor, and that causes cleavage of kininogen to bradykinin. Bradykinin is a small peptide that mediates vascular permeability, dilation of arterioles, and pain. And so it's an important mediator also of the inflammatory response. Nitric oxide is a compound synthesized by endothelial cells. It's produced when nitric oxide synthase acts on L-arginine to produce NO. And it acts to reduce and control inflammatory responses. It causes vasodilation. It causes decreased adhesion of leukocytes, decreased adhesion of platelets, and it's also microbicidal, which means it can kill microbes. Okay, so we've talked about what happens in acute inflammation. Let's talk about what some of the outcomes of acute inflammation are. What happens when acute inflammation occurs? Now, there's several things that can result from acute inflammation. One is you can have complete resolution of the inflammatory response. Two, you can have persistence of that inflammation, and that's what happens, for example, in an abscess. When you have a long-standing infection with inflammation, you can get abscess or persistence of that inflammation. You can get fibrosis, which occurs when tissue damage is replaced and healed by connective tissue, or you can get progression to a chronic inflammation. So this is illustrated here. Here's acute inflammation, either resolves by resolution, and that's what happens when you get clearance of the stimulus and without a lot of cellular damage, and so you retain normal function. You can get healing that's what happens when there's cellular damage that needs to be healed, and you get fibrosis as a result of that. Or you can get progression to chronic inflammation. And in that, you get angiogenesis, you get more mononuclear infiltrate, and you get more damage. And this can occur actually directly in chronic infections, viral infections, and autoimmune diseases. And that also results eventually in fibrosis. So chronic inflammation is something that happens when you get active inflammation, tissue destruction, and attempts at repair, which are proceeding simultaneously. And this occurs, for example, in a prolonged infection. The predominant cell type in this case is the mononuclear cell, things like macrophages and lymphocytes. And remember, you can get both a nonspecific or a granulomatous inflammation, which we'll describe in more detail in a minute. Now, granulomatous inflammation is a focal area of aggregation of macrophages. This is what happens when the macrophages dominate the chronic inflammatory response, and they're transformed into epithelioid cells, what we call epithelioid histiocytes, and surrounded by lymphocytes. This can occur when you get a foreign body, or when you get particular immune response, or when you get particular infections. And you can be non-caseating or caseating, depending on whether it's accompanied by necrosis. So if you get granulomatous inflammation with necrosis, you get caseation. If you get granulomatous inflammation without necrosis, it's called a non-caseating granuloma. Now, giant cells, which are multinucleated large cells, are often seen in granulomatous inflammation, but not always. So you don't have to have giant cells to call something granulomatous. So here are some of the causes, the infectious causes of granulomatous inflammation. Things like tuberculosis, fungal infections, leprosy, syphilis, and cat scratch disease. What causes them and the type of reaction that you get. And this ends the section